That's Pink taking us down to 6:15 here on your Monday drive. It is the 13th, the second Monday of the month, and we always bring you Vision Talk at this time on the second Monday of the month. And thrilled, sitting across from me right now is our rehab professional from Vision Bermuda. We have Teresa McMordy with us, and it is our pleasure to have a specialist with us today. We're welcoming Professor David Owens, who has been here as part of the Diabetic Month. Am I correct? The Diabetic screening series that's on right now?
Yeah, the retina screening.
Good to know. And Professor Owens joins us as, you know, a huge expert in the business. He's currently the chair of biomedical sciences and the clinical lead for diabetes-related retinopathy in the Diabetes Research Group at Swansea University Medical School. He also provides support to the Masters of Science Diabetes Practice course and supervision for PhD projects both in the United Kingdom and elsewhere. We'd like to welcome you to our little piece of paradise, Doctor, which has been very rainy lately, but thank you for coming and share with us some of your expertise, please. Teresa, what do we want to talk about first?
Absolutely thrilled that you're here. Thank you so much for joining me. So we're going to talk about diabetic retinopathy, please. And the importance of having eye testing. And
yes.
You know.
Well, I mean, let me initially thank you for the kind invitation to come.
My pleasure.
I've been involved in diabetic eye disease now for the last 20 to 30 years because, of course, diabetes was in the UK certainly the primary cause of visual loss and blindness.
I think Teresa will tell you that it's pretty much the same here.
So yes, I think globally speaking, numerically speaking,
sure.
It's the fifth commonest cause of blindness.
Okay.
You know, which means that about 1 million people known to be blind because of diabetes currently.
Sure.
And of course, that's a huge problem.
It is definitely a huge problem.
And the problem really is, of course, where other causes of eye diseases are improving.
Sure.
Diabetes is deteriorating, meaning that it has a bigger influence in terms of contributing to visual impairment. So, you know, where the population will increase globally by 20%.
Sure.
Diabetes is expected, in terms of blindness, is expected to increase by 46%.
Wow, those are big numbers.
And of course, it's the one main cause of concern for the patient, even more than the other complications of heart problems,
sure.
foot problems. So visual impairment is top of the list.
Now, is that mainly for the type 2 metabolic disease or for the inherited type 1 when it comes to diabetic retinopathy being the cause of vision loss?
Well, I mean, if you take the type 1 people
sure.
first, you know, and they're much fewer people.
Sure, much fewer, absolutely.
But the point is, when they develop their diabetes, well, of course they have no retinopathy.
Sure.
But given between 10, 20 years, you can bet your bottom dollar that up to 80% will have changes at the back of the eyes.
Sure.
Right? And half of those will have changes which we would regard as visually threatening.
Yes.
Now, the type 2 patients, the problem with the type 2 patients is that there are 4 or 5 times more of those than we have for type 1
The big
patients.
numbers, yes.
So therefore, numerically speaking, they're our biggest problem.
Yes.
Although the type 1 patients have more retinopathy per individual.
Understood.
As opposed to the type 2. Now, the thing with the type 2 patients is that because we don't really appreciate when the type 2 diabetes begins.
The onset, yes.
So therefore, 20% of people with type 2 diabetes already have retinopathy.
And they haven't even been diagnosed, you think, properly?
Well, they haven't. They haven't
yes.
been. Their diabetes has not been diagnosed. And of course, they're unaware that there are changes going on in the eyes. And that's the problem with retinopathy, is that by the time people recognize that it's impairing their vision,
sure. It's quite advanced, isn't it? Yeah. Could you just maybe explain, you know, in layman's terms and the Reader's Digest version, exactly what what retinopathy is to and how it pertains to what actually causes the sight loss. Now, I know a little bit, been to a few ophthalmologist conventions as an audiovisual technician, so I know a little bit about how the retina, of course, is where, our brain figures out what we're looking at, basically, is a short way to put it. And, we have rods and we have cones and we have certain things and certain layers within it that decipher what we're seeing, and our brain tells us what we're seeing. So what does retinopathy actually do to that,
right,
to cause the impairment?
Well, I mean, as you said clearly, the retina at the back end of the eye has cells, rods and cones that are particularly sensitive to light and interpret that signal, transmitted to the back of the brain into the sort of visual cortex, and we have vision. So the integrity of those cells in the retina, and of course the retina not only has blood vessels which provide oxygen and nutrients and also take away what all metabolites that we don't want from the eye.
Exactly.
And they are under the control as well of the neural tissue in the retina.
Right.
The problem with those is that we can't see them.
Got you. Okay.
We can measure them now with more and more modern technologies. So therefore, we interpret and understand that disease of the blood vessels, and especially the small blood vessels, is the key thing that we're trying to prevent. And these are called the capillaries, which are the link between the arterial system, the supply, and the venous system, which is the drainage system.
Which drains it away, exactly.
So those capillaries will decay in the context of high blood sugars or high lipids, and of course they will leak.
Got you, okay.
You see, they will either leak or they will block.
Okay.
In the type 1 patients, predominantly they will block.
Okay.
Right? And because of that, the area will be denuded of oxygen.
So it will die.
And some of the blood vessels try to generate new vessels in order to supply that oxygen to the very ischemic areas. The problem with those blood vessels are that they're very, very delicate.
And weak, yes.
And they will burst and bleed into the back of the eye. And there is an area in the back of the eye, which is the fovea, which is right in the middle.
The very center, yes.
And 80% of our vision is related to that area.
Got you. Okay.
So if you've got a blood vessel bursting into that or in front of it, then you will lose your vision.
Lose your sight, absolutely.
Now, on the type 2 patients, a slightly different pathology.
Okay.
Now, those capillaries that we were talking about, because they get damaged, they seep out plasma into the retina.
Right. And the retina does not like that, I'm sure.
It doesn't like it, and it stays there.
Yes.
And because there are fat in the plasma, fatty tissue, the fat is deposited there almost like concrete blocks.
And blocks your vision, literally.
So if they sit there on the fovea, the area we were talking about earlier, then they're going to lose their vision.
Got you, yeah.
But the problem is, as I said earlier, these changes in their early teens, right, the patient is totally unaware. Because these changes may happen outside these sensitive areas, but then encroach upon that area.
Eventually they will.
Eventually.
Yes.
And of course, it's pretty well advanced very often.
Yes, by the time they're diagnosed.
So we have to screen.
Yep.
Detect them early so we can interject.
Yep. So from what I understand, the screening through the Diabetes Association went very well. Like, it was maxed out. People were not messing around. They made their appointments. They came and they had them done. Now, I have seen in some of the stuff that I observed that you speaking of having, either capillaries or arterial, you can see inside blood vessels in the retina. Nowhere else in the body can you do that.
Yep.
So if someone is diligent about their annual checkup, seeing their GP, and part of that becomes screening with an optometrist or an ophthalmologist, depending on how insurance, how you refer to whatever, either one. Because then, if you were to do that annually, like you would normally through life, like you should, then, of course, you can see it in the retina very quickly if things like blood vessel disease is starting at the very, very earliest stages. If you are screened and someone can say, boom, this is what you need to start doing in order to prevent it. Because I think the thing we were going to eventually get to is that with type 2 diabetes and the issues with sugar and all, that's something we as first world folks have brought on ourselves to a large degree through poor diet and cultural practices that don't benefit our metabolizing our sugars well.
Yeah.
Basically. Yeah. So are you advocating, is that what we want to have as our general health plan? And
absolutely. I mean, I think universally, there's no question that eye care should be primary, essential national policy.
Absolutely. Yeah.
Everyone should be entitled in terms of with no discrimination.
Sure.
Right?
Yes.
Because, as you said, I mean, the policy is certainly that every individual over the age of 12 should be screened, and especially if they've had diabetes for 5 years.
For sure.
Because duration is another impact.
It is, yeah.
If your diabetes control is bad for a long time, you're much more likely to get it. So the policy initially is to screen people every year from that. And we can pick up even the smallest
changes, absolutely.
When we actually see even the smallest change, there are bigger changes around.
Absolutely, right? But you can arrest them if you have the knowledge, and that's the goal, yes?
If we can introduce then, ensure that the diabetes control, and we know how to measure that.
We do. We're very good at it now.
If the blood pressure is controlled.
Yes.
And if the lipid, the cholesterol and triglycerides
all of those, yes,
are also controlled, the probability is then in the early stages you will get some regression of those
symptoms.
Changes.
Yes, absolutely,
But if not, they can seize the development of those into a life-threatening situation.
Absolutely, yeah.
So it's not a problem for 20 years to have mild background retinopathy because it's not going to affect. Right, but it's essential to pick up these early changes because there are real early warnings.
Sure.
And not only diabetes complications.
Absolutely.
Because those blood vessels in the eyes are the same as the one that you have in your brain.
So if we're talking for hypertension and stroke issues and stuff.
Because the eyes and the brain blood vessels develop together.
They do.
So stroke, maybe dementia.
Sure.
We can predict by looking at the blood vessels in the eye. And that's what we are doing from a research and a futuristic point
I think that's pretty phenomenal for our listeners to grasp here. It's Teresa and I have spoken about that in sort of much more narrow terms previously on the program about the necessity of screening and the necessity, the hope that here in Bermuda, we have terrible issues with metabolic disease, whether you talked about hypertension and what you talked about cholesterol issues and of course sugar issues. So we're here talking with Professor David Owens, who is here through the Diabetes Association and also here as part of Vision Talk this week. And because he's an expert in the field of diabetic retinopathy, that's what we're sort of focusing on today, if you've just joined us. And we've just sort of made the call that, in any sort of health system, national health system, as it would be in the UK, is an ophthalmic examination part of what you can get with the NHS back in the UK?
Definitely.
Sure. And is it something that people are... or do you have to ask? Because sometimes you need to be your own best advocate. Like the patient has to say, you know what, I'm coming in for my annual. I need to get my eyes checked.
Well, we did rely on the patients.
Sure.
But in fact, now we have a system whereby whoever gets diagnosed with diabetes in primary care, for example, even a child at the age of 3 or 4 gets registered, right? With the diabetes service.
Gotcha.
So by the age of 12, there's a letter in the post, there's an appointment. So it's an automatic. Anyone who's known to be diabetic gets screened.
Gotcha,
right?
Okay.
Of course, they don't come. Not all
the time.
Come,
Yeah.
And of course, during their adolescent years, they go to college, they move house.
Sure.
So we sometimes
can lose track.
them.
Sure.
There are several, so there are obstacles, but of course there are sort of ways that we can ameliorate that. But we need to register, And what we have found in 8 years since we started the screening program, I mean, we started in 2001.
Gotcha.
Even, right?
Okay.
But over an 8-year period that we surveyed from 2015 up to 2015, well, over 8 years, we reduced
Wow.
serious visual impairment and blindness by 50%, 49%.
That's awesome.
So it's no longer number one in the UK. It was number one in the UK
Gotcha. Okay.
for a cause of registrations of blindness. You know, so you need to know what the blindness problem
What
is.
caused it? Yes.
And what causes it. So you need that target. So then, at the same time as we need a register of
Sure.
the patients, we need to know how many people have unfortunately been certified. So therefore, we can see whatever we are doing, is it having a good impact on that?
Exactly.
And because, as I said to you, we've been able to reduce it by half.
That's-
but we've got a half to
Got
do.
a ways to go, and I
Yeah.
think, I wonder, you know, because you've obviously been doing it for a long time. I saw you've heard several reports and spoke to several patients yourself, and of course with Teresa and I having this program once a month. Our main goal is awareness, you know,
Yep.
for our people to figure out that. You know, I know people who's, you know, they've had blindness in the family due to diabetes. Of course, some people are more predisposed to the type 2, depending on genetics as well, but it's not the genetic cause of type 1. We know that. But again, it is about choices. It is about life, cultural memes and lifestyle that you've become used to. So what do you think is I'm sure you just talking on this program now is going to make the penny drop for
really
some
hope so.
folk. We really hope so. Do you think it's more about getting, you know, GPs to say, okay, you know, obviously they see someone come in, you can look at people and see if they're living perhaps not such a healthy lifestyle or not, and say, hey, you want to do this right now. And with so many young people now dealing with weight problems and sedentary lifestyles and so on, you know, it's hard. Your parent needs to know, look, you know, if your child's, you know, on the edge of having sugar here, they need their eye screen. They need their eye screen. They need their eyes screened to get that message across, because the preventability of it, I think, is probably the thing that needs to be highlighted, perhaps in literature and marketing going forward.
I just want to go back
Sure.
a minute to what you said about, you know, looking what you see in the eye.
Sure.
Because that penny's just dropped for me after all my years of working with people with eyesight, sight loss, that you can see the pathways to potential stroke and dementia
Absolutely.
just
Oh, yeah,
by
of
having
course
your
we
eye.
can.
I had no idea.
Cardiovascular disease?
Yes,
No.
definitely
I
cardiovascular
think,
disease.
You know, really need to put that across now. I
Sure.
think that's really-
Artificial intelligence now has also demonstrated that purely by looking at the retinal image, they can determine, as well as any other risk equation, the probability of cardiovascular disease.
Sure.
Just
sure.
by looking.
Yeah.
They can tell you
It's
almost the
amazing.
age, whether
Yeah.
you're a smoker,
Yep.
what the HbA1c is. I mean, not as good, not spot on.
Like a blood test or something would be, but pretty damn close.
Pretty
Yeah.
near.
I
That's
remember, and it's going back probably almost 5 years now when I did, for some reason, 2 sort of eye-related conventions here on the island, and I'm being an audio-visual technician at these things, so I'm just there to help presenters present, basically. And both of them talking about what we just mentioned, that the vessels in the retina are the only place you can see inside a blood vessel without opening it up, without
Absolutely.
opening the body up. So
Absolutely.
let's get a hold of this, folks. I guess I'm thinking I'm a little bit like, well, what's the hold up of having this trumpeted? I mean, we see so much from Big Pharma
Absolutely.
on network TV about preventing, everything from, and there are a lot of, products on the market now for lowering A1C, like you mentioned. There are so many lowering cholesterol products again, but again, that's, there's studies and there's side effects and there's this, that, and the other, and the medical profession is trying as hard as it can, basically, to say, here, please, if you're not going to do X, Y, and Z, please take this, so you have, whatever chance of mitigating your disease, however you want to do it. But I think it just needs to be out there that things like stroke and heart attack can be prevented if you get your eyes examined.
Well,
It seems, and I know it's not that simple, but the concept is, correct?
In fact, the concept is simple, as
And
you
it is
say.
that simple, but
And it's factual.
Sure.
Right?
Okay.
So, because if you look at the eyes, as you've absolutely plainly said,
Sure.
if the risk of heart disease or something is a high risk,
Sure.
then we know those things that we have to modify.
Yes.
We have to make sure the blood pressure is fine. We have to make sure the lipids are fine.
Sure.
We have to, and for diabetes, we need to make sure the control is fine.
Yes.
And we know if that's the case,
Yeah.
then hopefully we can stop the progression
Yes.
to any damage. And of course, this reflects damage to the kidneys,
Sure.
damage to the nerves,
The rest of
the
it.
amputations.
Sure, we're talking about pulse and blood flow to the extremities that in diabetics are often the outcome, a negative outcome after
Yeah.
long-term disease. Yeah.
So I think the initiative by the Bermuda Diabetes Association, the Vision Bermuda, is absolutely critical.
Sure.
Right?
Yeah.
There is no excuse anymore. And of course, the United Nations, the World Health Organization, there are booklets to say, you've got to do these.
Sure.
You are a signatory to the United Nations.
Sure.
So get on with it.
Get on with it, yeah.
So the policy makers...
Yes, need to make the policy. Thank you very much.
We have been in many countries now.
Sure.
Especially, say, we went to Mauritius
Sure.
for a 5-year period, meaning that we would visit 2 or 3 times a year.
Yeah.
Right? So basically, we again reduce the cost that visual impairment imposed on the economy
Sure.
by 2/3
Awesome.
in that time.
Uh-huh.
So therefore, it's absolutely mandatory that in our policy now we try desperately to have a chat with the policymakers.
Sure.
Right.
Uh-huh.
The Minister of Health.
Sure.
Right.
Uh-huh.
And in Mauritius, we were lucky that the Prime Minister was a physician.
There you go. That's helpful.
He understood.
Yeah.
He supported us, and from a single laser therapy in Mauritius, now they have the full modern technology.
The full-on
right?
thing, yeah. Great.
So the population has benefited. The economy has benefited.
Absolutely, because I think what you're trying to say, Doctor, not cutting you off, because I think that connection really needs to be reinforced, especially because right now in Bermuda, our healthcare system is in the process of trying to be improved upon, and it's been in a revamping stage for various amounts of years in various administrations. So, the minister has changed from time to time, but knowing, I think if you talk to their wallet, that's the thing people say about if you want to get things pushed forward and you're going to show someone a cost savings. And I think that's the key. Talk to the wallet and say, hey, we're going to save you in healthcare costs down the line by having this preventative stuff done. Yes?
Well, that's the way we approach. I mean, as physicians, non-ophthalmologists,
Sure.
with an interest in the eyes,
Yes.
we realized quite early on that it's quite skillful to detect eye problems
Sure.
with the eyes. And we actually adopted screening and utilizing cameras technology because that made it easier for us.
For you to
right?
diagnose, yes.
So we did a program in the southern part of Wales, in a couple of regions,
Sure.
and were able to show that we were detecting much more disease than we previously did.
Sure. With new technology.
So we went along and did a study finding that it was costing the government so many millions a year for this number of people who'd lost their vision.
To care for them, yes.
So social services cost, and it's not only that, but
Sure.
people who've lost their vision, they fall,
They hurt
stay longer
themselves
in
hospital, yes.
So basically we said, look, give us part of those millions
Sure.
to set up a screening service. And luckily, we had a Minister of Health who understood.
There you go. Yeah.
She said, okay.
Okay.
Right? Because we had to argue against other specialties.
Of course.
And they used to say, so why should we give you all this money? What are you going to tell your colleagues in other specialties? And I said, That's their problem.
That's their problem. Yes, that's their problem. That's not why you're in healthcare. Is to maintain longevity of a practice. You're in healthcare to help save lives. Generally, I think most good doctors are. So I mean, I think we're hitting the right nails with the right hammers right now, because, we can all go banging away at things, like you said. Administrations are pulled, from left to right and all over the place for where to allocate money, and especially in healthcare. And we're talking about an aging population as well here in Bermuda to a large degree, and in several other places around the world. So all of this, we're saying to say, the work being done by Vision Bermuda, the work being done by the Bermuda Diabetes Association is tantamount to making healthcare viable, being able to cover the costs of it in the most efficient way. So, your annual checkup, the first thing needs to be your eye screening.
And if I can just add to that, in my caseload, so I've been here coming up to 2 years, a good third, if not a little bit more, of my caseload, my clients have diabetic retinopathy. Most of them are now blind.
Blind, yes.
And weren't aware of the risks of not, trying to weren't aware of this.
Halt the progression of it initially with their and are they, and they're all been diagnosed diabetic for a while?
Well, that I'm not quite sure on. But the other thing is, I'm getting in this last year, say, many more clients who are actually work age and now aren't able to work
because their sight is that damaged.
So they're from 40s to 55.
Got you. Yeah.
And that's because I keep that data, and that's quite incredible. And I'd say, like I say, over the last 8 months, a year, that these clients have come on my list.
Sure.
So, we were estimating, as I said earlier today, we were estimating that 13% of the Bermudan population have known diabetes.
Known diabetes,
right.
Yes.
For every known one, we anticipate there's another one out there.
There's one that isn't been going to the doctor.
and those people with impaired glucose tolerance sitting in the wings, ready to come on board. Right?
Sure.
So, but then looking at the prediction for this area of North America and down to the Caribbean, which we regard in terms of the IDF, which is the International Diabetes Federation, that is going to increase by 24% over the next 30 years, right? Which means that for 16% minimum of the population will have diabetes. A third of those will have retinopathy.
Sure.
And 10% of those will have sight-threatening lesions.
There you go.
Right?
Yeah.
So that's going to tell you, put your hand in your pocket, because it's going to cost you a lot of money.
Absolutely.
But it's not only that, it's the personal cost.
Absolutely, the quality of life, yes.
The vision, the quality of life, contribution to the family,
all of the above.
Self-preservation,
yes.
Everything. It's just destroys people.
It can.
Vision loss.
But it can be prevented. Let's put that out there.
80 to 90% is known to be preventable and treatable.
There you go. There you go. For those just joining us, we've been having a very fascinating discussion on diabetic retinopathy here today for our monthly Vision Talk chat. Of course, Teresa McMorty, the vision specialist, and Professor David Owens, who is the clinical lead for diabetes-related retinopathy in the Diabetes Research Group at Swansea University Medical School. And he also provides support in the Master of Science Diabetes Practice course and supervision for PhD project. I've been totally fascinated by your amazing recall of all the stats that you talk about, and I think the way you speak about it with the passion that can be heard in your voice about how we must push this piece of string along a little faster to make it sort of mandatory, or just what is the regular annual checkup for folks, especially if you're looking in high risk and so on and so forth. So I think we've said a lot today, and I want to thank you for your time, and hope that you get a little bit of sunshine for your stay here, sir. And perhaps we can look forward to perhaps you coming back again at some point. I'm hoping the relationship will continue, and there will be follow-ups in your be able to come and visit our little piece of paradise out here in the middle of the Atlantic. It's been a pleasure having you here. I'm sure, Teresa, is there anything we want to wrap up with? And then
just thank you so much. I knew this would be a fascinating report, so thank you so much. Next week,
next month?
Next
okay.
month. It feels like a week to me. It comes around so
Sure.
quick. We'll be looking at nutrition
Sure.
and how to support your sight loss with good nutrition.
Absolutely.
So I think that follows on beautifully from
It will
today.
do, because good nutrition can prevent the onset of diabetes too. So there you go.
definitely.
It's all related, right?
Yeah.
Thank you so much,
Thank
Professor,
you.
for being
Yeah,
here.
thank you very much.
And
Very nice to meet you.
We wish you safe journeys in your travels, and please keep waving that flag for us and for everyone
Will do.
around the place.
We'll do our
Okay,
best.
we do appreciate it, folks. Vision Talk, heard, I should say, once a month, the second Monday of the month, right here on Ocean 89, Bermuda's best music mix. You can't say you didn't know, because we just told you all about it. And we hope, like us sitting in the room here today, that we're all a little bit smarter and a little bit more aware of things. Thanks, you guys, so very much for coming.
Ocean
Appreciate you.
89.